Hello, and thank you for taking time to watch this webinar. My name is Shelby Jobe, and I am the Director of Communications at the Arizona Medical Association. This webinar is being led by our valued partner, the Mutual Insurance Company of Arizona, which you might also know as MICA. ARMA, MICA, and our other valued partners are committed to meeting you where you are to deliver the knowledge, resources, and services you need to excel in the practice of medicine. And this presentation is one way we're fulfilling that commitment. MICA has been putting physicians first since 1976. Since then, they have focused on offering medical malpractice insurance coverage that physicians and medical professionals can count on at sustainable rates. By keeping their insureds top of mind, MICA has become the market leader in Arizona. MICA's success is in large part due to its amazing team, which includes Karen B. Everitt, JD, BSN, who serves as Vice President of MICA's risk team. Karen has over 30 years of legal, medical malpractice insurance, and critical care nursing experience, and she has a long track record of successfully driving positive change at department and corporate levels. The risk team contributes to MICA's historically outstanding service and mission to protect and defend the practice of medicine with research-driven expertise, effective risk assessments and consultation, and pertinent liability and risk management content. Before her time at MICA, Karen earned a Bachelor of Science in Nursing degree from Auburn University and a Juris Doctor degree from the University of Alabama. Karen is a member of the Alabama State Bar, the American Health Lawyers Association, the Defense Research Institute, and the American Society for Healthcare Risk Management. And with that, I'll give Karen the reins so she can lead us through her presentation on managing medical record documentation. Karen, please take us away.
Hi, everybody. I'm Karen Everitt, and thank you for inviting me to present this webinar. I do not have any disclosures from a CME standpoint. I hope that after this webinar, you will be able to recognize effective medical record documentation and be able to state a documentation strategy to improve documentation and patient outcomes. Documentation is a multi-tool. It helps you get paid, it helps facilitate communication, it helps prove your care. To get paid, you and your staff or team must document the things in the medical record that the payor wants to see. Unless you are willing to move to an all-cash practice model and stop seeing Medicaid and Medicare patients, you have to document what the payor requires. A payor wants your documentation to support their definition of medical necessity before they send you a check. You are likely contracted with several payors, and their definitions differ. A payor also wants your documentation to support a plan of care. Payors are not healthcare providers. Most are for-profit businesses who want you to help the patient achieve their best possible outcome for the least amount of money to ensure a profit. They see plans of care as a way to monitor your capacity to ensure a profit. Documentation is also a way the care team communicates with each other and the patient. You cannot talk on the phone or have a face-to-face conversation with each and every member of the healthcare team. The medical record is how you talk to each other, and now it's a way for you to talk to your patients. Under the open notes or information blocking rule, your patient should have immediate access to almost all your documentation. Most patients won't understand the way you talk to other physicians, coding and billing staff, pharmacists, and ancillary services through the medical record. The rule means you will talk to them during an appointment and through the medical record. Finally, documentation is about proving your care. That's why I'm here. I'll talk about how licensing boards see your documentation when there's been a complaint about your care, and the board is considering whether to investigate further. I will also tell you about some cases where documentation was successfully used in defense of some medical malpractice claims and where it was used against physicians. I'm not qualified to give you coding advice. I might know some basic information and principles from law school or continuing legal education courses, but I'm not qualified to advise you on compliance. Asking me to talk about coding is like asking a cardiologist to deliver a baby. So why am I bringing it up? I'm bringing it up because you have to get paid. There is also some crossover from documenting for reimbursement and documenting to defend your care. The Centers for Medicaid and Medicare Services offers an example of insufficient and sufficient documentation to support the medical necessity of a power mobility device in a beneficiary's home. Of course, the documentation likely to result in payment is longer and more detailed. That's what it takes to meet CMS's definition of medically necessary and a plan of care for a scooter. As scientists, I hope you can also appreciate the use of numbers, data, objective information to support not only why the patient needs a scooter, but also why the physician thinks the patient can actually use a scooter if CMS will pay for it. The likely insufficient for payment note is what most malpractice defense attorneys have to work with in a lawsuit. The likely sufficient for payment note is a medical malpractice defense attorney's dream. Most physicians have little to no recollection of the patient who filed the lawsuit, let alone the details of their care. CMS is looking for documentation that meets their definition of plan of care. A jury is looking for documentation that explains the physician's thought process at the time. Testimony about the physician's recollection is good if the physician can remember, but the jury would prefer the likely sufficient for payment note that makes up for the lost memory. A 30-day supply of 100 milligram Januvia tablets is between $500 and $600. The patent doesn't expire until 2026. CMS sees a plan of care as a way to monitor your capacity to ensure CMS doesn't overspend on all patients with diabetes. The likely sufficient for payment note is what a malpractice defense attorney needs to prove your care after the patient sits on his or her side effects, possibly dies, and the patient's family says, you never warned the patient, and now you can't remember the patient, the visit, or the care. You'll be proving your care to a licensing board should the patient file a complaint. Dear doctor, you are being notified that the Arizona Medical Board received a complaint report, self-report, and an investigation has been opened to determine if further review is required. Attached is a copy of the complaint in its entirety. Nothing is required of you at this time. Should the investigation merit further review, you will be contacted by an investigator to provide a written detailed narrative and any other necessary information. This might be the letter you receive following a patient filing a complaint. And the copy of the complaint may only be a paragraph or two, and you may or may not fully be able to understand the crux of the patient's complaint. I find that physicians quick to defend and explain their actions often lack experience and insight into medical board procedures and investigators' techniques that could result in disciplinary actions, such as reprimands, censure, probation, or license suspension or revocation. An uninformed and emotional response to the allegations could negatively affect the strength and effectiveness of the defense, especially responses submitted without the assistance and guidance of an attorney. Some medical malpractice insurance policies, such as MICA's, may reimburse physicians for legal fees and attorney's bills for representation in a licensure board action up to a certain amount. Medical board investigations are not always straightforward. An investigator may request a meeting, but not fully explain the focus of the investigation. An investigator may use meeting notes in the investigation and the disciplinary process without ever sharing them with the physician. A lawyer experienced in licensing board investigations will contact the investigator, ask the right questions to peg the issues, and draft a helpful, protective response before the deadline. I have seen physicians represent themselves, decide to dismiss the board's request for records, not respond, and subject themselves to discipline for not responding. You have a chance to make a positive impression on the licensing board investigator when you comply with the request to provide a copy of the patient's medical record. This is the investigator's first time to meet you. Now, when electronic health records were new and the board investigators had not learned about EHR printouts, this is how the investigator first saw you. Patient complains of rash and infection on left cheek times 4 weeks. Also has a mole on his back that would like to get evaluated. Patient complaining of, for 2 weeks, rash on his left cheek. He also developed a rash in his left axilla under the skin fold and right side of chest. Patient denies head, glove, or shoe size changes. Patient denies rashes, itching, sores, bruises. We hope licensing board investigators go through some version of cognitive biases training before reading through a licensee's medical record documentation, that as professionals and sometimes physicians, they can effectively manage their responses to their first impressions. Here's another first impression. Patient complains of dizziness and some spaciness since this morning. Patient comes in complaining of dizziness and fatigue in the morning. Patient denies fatigue. Patient denies head, glove, or shoe size changes. Patient denies vertigo. Most medical boards dismiss most complaints against physicians, but an investigation may lead to severe licensure actions. You may find yourself proving your care to a jury. This is how it begins, with a letter from an attorney. Please be advised that this law firm and I represent your patient with respect to claims that she has against you related to and arising out of a procedure performed on XYZ date. Or the purpose of this letter is to inform you that our office has been retained by your patient to represent him or her in a possible medical malpractice action against you related to a prescription you wrote for XYZ medication with an improper dosage. So let's see how some of these letters play out. I told an audience in Wisconsin about a case with very specific and unusual facts, but did not identify the defendant, physician, patient, or location of the care. After the presentation, a physician from the audience admonished me for sharing a case about a physician from that county who was revered and respected by everyone in the room, who grew up there and went to college and medical school there. I told the physician that many physicians think, I know that case, I know that doctor, and are surprised to learn that very specific and unusual facts are not as specific and unusual as they think. I told the physician that the defendant was from another country, went to medical school in another country, and the case was tried in the southernmost county in the contiguous US. In our first case, the defendant plastic reconstructive surgeon obtained the plaintiff's informed consent for breast augmentation and implants. The plaintiff had lupus and had been taking Plaquenil and a prescription anti-inflammatory for several years. The defendant surgeon had done a few minor successful procedures on this plaintiff. The defendant documented in an office visit note the plaintiff's choice of very large implants. The plaintiff's post-op course and healing were less than ideal, including infection, necrosis, and resulting in the removal of the implants and scarring. The defendant surgeon did not address delayed healing due to lupus in an informed consent note in the medical record, but the surgeon's 14-page consent form did, and covered a few other things that came up in the case. Here are the things that were covered that became important in the case. Major wound separation. Wounds may separate after surgery. Should this occur, additional treatment, including surgery, may be necessary. Delayed healing. Wound disruption or delayed wound healing is possible. Some areas of the skin may not heal normally and may take a long time to heal. Areas of the skin may die. This may require frequent dressing changes or further surgery to remove the non-healed tissue. Additional surgery necessary. There are many variable conditions that may influence the long-term result of surgery. It is unknown how your tissue may respond or how wound healing will occur after surgery. There are general risks associated with healing, such as swelling, bleeding, possibility of additional surgery, prolonged recovery, color changes, shape changes, infection, not meeting patient goals and expectations, and added expense to the patient. Individuals with weakened immune system, currently receiving chemotherapy or drugs to suppress the immune system, conditions that interfere with blood clotting or wound healing, or have reduced blood supply to the breast tissue from prior surgery or radiation therapy treatments may be at greater risk for complications and poor surgical outcome. Large volume primary augmentation or revision with larger sized implants in excess of dimensional planning for your chest and breast size may increase the risk of complications such as explant extrusion, hematoma, infection, and the list goes on. Specific risks of silicone gel-filled breast implants. It is possible to predict the biologic response that a patient's tissues will exhibit to the placement of breast implants or how you will heal following surgery. Finally, general risks of surgery. Certain medical conditions, dietary supplements, and medications may delay and interfere with healing. Upon receiving a copy of the consent form, the plaintiff in this case dismissed the lawsuit. I hope you read about informed consent requirements for breast surgeons in a MICA newsletter last year. The U.S. Food and Drug Administration requires breast surgeons to provide specific information and use a 16-page consent form. Arizona's new breast implant law, effective January 2022, requires physicians to provide very specific information and use a 6-page consent form for breast surgery and implants. Arizona breast surgeons must use both processes and forms. The 14-page form used in this case was very close to the now required forms. In our next case, the plaintiff's right arm was amputated after a right shoulder arthroplasty. The plaintiff sued the orthopedic surgeon and the hospitalist in charge of her care in a rehab hospital. The crux of the case against the two defendants was whether the brachial embolus was present under the surgeon's postoperative inpatient care or under the hospitalist's inpatient rehab care. Expert witnesses for the defendant hospitalist were supportive and believed the complete occlusion occurred shortly after surgery, before the defendant hospitalist saw the plaintiff, and profound ischemia had already occurred. The defendant hospitalist's attorney was initially optimistic, then learned new information about the defendant's medical record documentation. The plaintiff had obtained a copy of her medical record before filing the lawsuit and obtained another copy after filing the lawsuit. In the first copy, the defendant hospitalist signed and dated the admission orders the day the plaintiff arrived at the rehab hospital. Here are a few other things. After the plaintiff's discharge from the rehab hospital 2 months later, the defendant changed the date of his signature to 2 days after the date of admission. Later, during deposition, the defendant said that he had not seen the plaintiff on the admission date, although he was in the hospital that day, saw the plaintiff 2 days after admission, and was afraid his error dating his signature would indicate he saw the plaintiff sooner than he did. Also, prior to the plaintiff's discharge, the documentation of a consult said in the morning. After discharge, it said stat. A jury never got to determine which defendant was at fault. Because of these documentation problems, the defendant hospitalist settled the case, and the details are confidential. In our next case, the defendant orthopedic surgeon diagnosed the plaintiff with osteochondritis dissecans and discussed ankle fusion or total ankle arthroplasty. The defendant offered to refer the plaintiff should she choose an ankle replacement. Over the next 18 months, the defendant surgeon treated the plaintiff with Depomedrol injections and answered the plaintiff's questions about surgery. Early on, the defendant surgeon documented a 30-minute discussion with the plaintiff. The surgeon recalled drawing the plaintiff a picture of the procedure. At another appointment, the defendant surgeon recalled an informed consent discussion with the plaintiff, and again, drawing her a picture of the procedure. At yet another appointment, the defendant surgeon recalled going over the procedure, the expected postoperative course, and the intended benefits and potential complications, including non-union, infection, amputation, removal of hardware, and continued pain. The defendant surgeon documented in the operative note that removing 5 millimeters of the talar dome and giving a 5-degree downset in the ankle because the plaintiff wanted to wear high heels. The plaintiff's recovery did not go well. She continued to experience pain and even said that it was unrelieved and worse than prior to the surgery. Hardware removal did not improve things for her. The plaintiff sought a second opinion, and the orthopedist documented that the plaintiff's foot was fused in a slight plantar flexion to accommodate a shoe. The plaintiff continued to see the second opinion orthopedist and did not return to see the defendant surgeon. The second opinion orthopedist documented the plaintiff's foot was in a poor position for function, an equinus position with varus, with the plantar flexed 15 degrees. The plaintiff sought yet a third opinion. The third surgeon suggested the plaintiff could consider amputation as a resolution to her ankle pain. He noted the plantar flexed 40 degrees. The plaintiff did not pursue another surgery and instead pursued a lawsuit against the defendant surgeon, alleging the defendant improperly performed the surgery, leaving her foot in a deformed position. The defendant's expert witness was supportive, saying the plaintiff's foot was in an equinus varus position before the surgery, and that surgeons are known to fuse ankles to some degree of equinus position to allow the patient to wear high or higher heeled shoes. The defendant explained that a 5-degree ankle is normal, but given the plaintiff's desire to wear high-heeled shoes, the plaintiff agreed to a 10 to 15-degree ankle. The defendant said he and the plaintiff spoke numerous times and at length about the 10 to 15-degree fusion and how it would really limit what the plaintiff could do. The defendant said the plaintiff understood the risk and wanted to proceed. Unfortunately, the defendant surgeon never documented this information in the medical record. So the defendant surgeon had documented the discussion 18 months prior, but had not included the picture in the medical record. The defendant surgeon had not documented the discussions or included the pictures in the subsequent medical record entries. The plaintiff testified at trial that she was able to place her foot flat on the floor before the surgery, and the defendant never discussed fusing her ankle in a 15-degree plantar grade position. She testified she would have never agreed to the surgery if she had known her foot would be placed in a 15-degree position, but did acknowledge the defendant examined her shoe before the operation and said she wanted to be able to continue to wear that shoe. During the trial, several jurors nodded their heads up and down as if in agreement, while the defendant and his expert witness testified. The jury's reaction seemed favorable to the defense, but the jury found in favor of the plaintiff. One juror was willing to answer questions after the trial. She laughed repeatedly at the plaintiff's expert witness and shook her head in disagreement on almost every occasion the plaintiff's expert witness criticized the defendant. She said that while she felt angry at the plaintiff attorney for bashing the defendant, she could not get past the defendant's repeated documentation that he had fused the ankle at 5 degrees. She believed the defendant surgeon did a good job on the surgery and improved the patient's mobility, but the documentation error occurred 3 times in the record. In our next case, the defendant, GYN, diagnosed the plaintiff with unilateral left-sided hydrosalpinx. The defendant, GYN, obtained the plaintiff's informed consent for, quote unquote, removal of one hydrosalpinx to prevent ectopic pregnancy and for successful pregnancy. The defendant, GYN, also documented discussing salpingectomy. The consent for sterilization form said consent for sterilization and bilateral tubal ligation. During the procedure, the defendant, GYN, saw problems with both tubes and removed both. The operative note stated bilateral salpingectomy, and the postoperative diagnosis was bilateral hydrosalpinx and right ovarian cyst. Following surgery, the plaintiff attempted several intrauterine inseminations without success. During evaluation by another infertility specialist, the plaintiff said she learned that the defendant, GYN, had removed both fallopian tubes. The defendant, GYN, used speech recognition software for office visits, although was not consistent in using it at every visit or in turning it all on and off to capture entire conversations. The defendant, there was not a recording of that postoperative appointment where the defendant explained about the test results, what procedures might be needed. I'm sorry, there was not a recording in the preoperative appointment with explanations about test results and the procedures that might be needed, including the possible need to take out both tubes. The defendant, GYN, believed he or she explained the removal of both tubes during the immediate postoperative discussion but did not document that and could not later recall the substance of the discussion. There also was a recording of part of the postoperative office visit. I'm going to read you the transcript of that recording that was placed in the medical record. Better now? Was it bad? All right. Well, this is you. All right. And so I went to make sure that you have every capability. Okay. All right. So there's both sides. And then here's the end product. I removed the tube. See, it's not there. It's not there. I did take a look up top, baby, having go inside. We do survey and we look around and we say, okay, what's going on and what's not going on and what not. So the were one reason for hypersonic thing, unfortunately, is infection sexually transmitted infection. Unfortunately, okay. And then you have some scar tissue in a huge over cause fits huge Curtis, which is consistent with me be lonely long time ago having sexually transmitted infection. Okay, and so it's what it is, and it's not going to affect you have a causing long-term problem. But it does kind of answered a question like this. It's kind of leaguer the way it happened, all right? These are your let your belly. Great. Orion. Would have been cheaper fall off, but it was known as the irritating. The plaintiff attorney sent a dear doctor, I represent the interests of your patient letter to the defendant GYN, alleging malpractice arising from the removal of both fallopian tubes. The claim was settled. The details are confidential. I'd like to tell you about a case involving review of prior medical records. The patient came to the emergency department with complaints of numbness and tingling in his left arm. The defendant radiologist's impression of the chest X-ray was no acute cardiopulmonary disease with a normal cardiomediastinal silhouette and age-appropriate atherosclerotic changes to the thoracic aorta. Almost a year later, the patient came to the emergency department with complaints of chest pain. The same defendant radiologist's impression of the chest X-ray was the same. No acute cardiopulmonary diseases, normal cardiomediastinal silhouette, and age-appropriate atherosclerotic changes of the thoracic aorta. Later that afternoon, angiography without contrast showed a small aortic dissection. A second angiography about 12 hours later showed a type 1 aortic dissection. The patient coded during the second angiography and died. The patient's family alleged the defendant radiologist incorrectly interpreted the most recent chest X-ray because their expert witness said the chest X-ray clearly showed an enlarged thoracic aorta and that the incorrect interpretation delayed diagnosis of the dissection for 12 hours. The defendant radiologist testified that her training ingrained in her to review the patient's prior studies. And when she opened a new study in the health system's EMR, the system provided a list of all previous studies. Usually she could choose to open and read the previous studies. The defendant radiologist recalled attempting to review the patient's prior chest X-ray from a year ago, but did not document that attempt or that she was unable to retrieve that study. She testified that had she been able to compare the previous and current chest X-rays, she would have reported a change in mediastinal width and an enlarged aorta and contacted the ED physician regarding the need for chest CT. Instead, she documented no acute abnormalities on the current chest X-ray. The plaintiff's expert witness testified the standard of care required the defendant radiologist to document there was a prior study she could not access and issue a preliminary report indicating attempts to retrieve the prior study for comparison. However, the expert witnesses for some of the co-defendants in the case testified the prior study was unnecessary because the current study should have caused the defendant radiologist to recommend the CT to the ED physician. The plaintiff and the defendant radiologist agreed to settle the case before trial. If you want to contact me after this webinar, please feel free. That is my direct phone number. I don't have a secretary, and so it will be me answering. You're also welcome to email me. When we were younger, we were often told that something was important if we found a gold nugget. Well, times have changed. Kids don't necessarily understand the analogy to a gold nugget. So I've changed it to a chicken nugget. Here's your chicken nugget for today's presentation. No defense attorney in any state across the nation has ever said, I had too much documentation. I wish the doctor had not documented so much. It was just too much. Also, some other mini nuggets: make the time for correct and appropriate entries for all potential users or readers of the medical record. Effectively represent the patient while you're documenting. Effectively represent your thought process and clinical decisions. You will most likely not remember them later. Give yourself credit for your work and your time, and comply with contractual requirements and state and federal law. I think we've got some questions now from the audience.
Yes, Karen, that was a fantastic presentation. Thank you so much for sharing your robust knowledge. And so thinking about the physicians that I work with every day, I do think that they would have some follow-up questions. So we've have a couple here to ask of you. And the first one is to do with time, because we know that we're always looking for time and there's never enough of it. And so one thing I can imagine that physicians would ask is, you know, there just simply is not enough time in the day to document all of these things for malpractice and reimbursement. How would you tell them that they can get this done?
Thanks, Shelby. I don't know if I can tell physicians that they can get all of this done. Instead, what I might ask the physician is, which risk are you willing to take? If you don't document everything needed for reimbursement by a third-party payor, are you willing to risk not being paid? If a patient files a complaint with a licensing board and you haven't documented everything, are you willing to take the risk that the board might take a licensure action? And third, if you're sued for medical malpractice, you didn't document, is that a risk you're willing to take to receive a judgment or a verdict against you? So I don't know that physicians can get all of this done in a day. It's overwhelming, it's voluminous. At times it probably feels to them to be phenomenal, but think about which risks you're willing to take.
Thank you, Karen. That really puts it into perspective, talking about which risk you're willing to take. And I know this is a day-to-day practice that at times just kind of feels, maybe it may be just a nuisance, but, you know, again, it's always about which risk are they willing to take. So the second question that we have is, why does MICA recommend I keep my medical records for so long? Does MICA know how much that will cost me?
This is a frequent question on our hotline, especially as physicians are retiring or leaving a practice and contemplating what to do with those medical records. The law in Arizona doesn't require physicians to keep records as long as we recommend. the reason we recommend physicians keep records longer is that although the statute of limitations may have passed, although the requirement to keep the records for 7 years has passed, it is still possible that a plaintiff could file a lawsuit and the physician would need those records to defend the lawsuit. It's extremely rare for a lawsuit to be filed 7 to 10 years after the event, but it has happened on rare occasions. So as the malpractice insurance carrier, our thought is about defending a lawsuit, defending the physician in the lawsuit. And we think our defense attorneys need everything. We also don't differentiate in keeping the different parts of the record. We don't differentiate between keeping the billing, the insurance information, the office visit notes, the images. We recommend physicians keep everything as long as possible, but no less than 10 years. And again, there's lots of practice management considerations with that recommendation. We're coming at it from, we don't want the physician to be sued and not have a medical record for the defense.
Wonderful. Thank you for sharing that. It's always better to be safe than sorry. It seems like that applies here. So our next question is if I'm sued for malpractice because the patient says I didn't consent her, why do I have to testify? How come the consent form isn't enough?
Well, first I'd like to comment that while physicians may say, I consent the patient, it's actually the patient who gives consent. And it's the physician who obtains that informed consent. Second, jurors are still people, and they may hear the judge's instruction that they may consider the information that was contained in the form and the fact that the plaintiff signed the form. But because jurors are still human, they want to hear what the physician has to say transpired in that informed consent discussion, and they want to hear what the plaintiff has to say. That is what they remember in the deliberation room. In mock trials, filming jurors who are discussing informed consent issues, they generally toss the consent form aside and want to talk about, now what was it the physician said? What did the doctor say? So importantly, it's important to get the consent form signed and to document that there was a discussion. That gives the whole process a human aspect.
Perfect. Okay, so switching gears a little bit, our next question asks, what do you think about offering things for cash that aren't FDA approved?
My first thought as an insurance professional is if you want to offer things for cash that are not FDA approved, to call and talk with your underwriter or your insurance broker to make sure that you have coverage, especially with regard to the non-FDA approved part of things. It's frequent that physicians prescribe FDA approved medications for reasons or applications that weren't in the FDA's approval. And that is certainly within the physician's professional authority. It is also possible that the physician might prescribe something that's not FDA approved. While that is legal, it may be a little more difficult to defend. And so if physicians are contemplating prescribing the non-FDA approved medications, I recommend that both contacting your underwriter or your insurance broker and starting a file with all the evidence that supports the use of this non-FDA approved treatment or medication, because that's the file we're going to need to defend you when there's a lawsuit. We're going to need you to go ahead and identify experts in the field and research and other evidence that this was a good decision.
Okay, wonderful. And so that brings us to our last question, which is just simply, where can I get more information or advice on documenting for reimbursement?
For practice management type advice, especially with documentation and billing and coding, I recommend that you first contact ARMA's Practice Solutions Service, run by their director, Juliana Stanley. Juliana came to ARMA with years and years of practice management experience and also practice management consulting experience. And I bet she is going to be able to help. So that's my first recommendation. My second recommendation, if you're not able to work with Juliana at ARMA, to get in touch with one of the larger accounting firms in Arizona, probably in Tucson or Phoenix, and look for an accounting firm that has a healthcare division. Often these large accounting firms are able to help with practice management questions. You just might not think to get in touch with them for help.
Well, Karen, thank you so much. That does bring us to the end of this webinar, and we really appreciate you spending your time and sharing your expertise with us. And we also are grateful for everyone who's tuned in and is watching. So for more information on this and other topics, there are additional places that you can go to learn more, and that would be both MICA and ARMA's websites, which we've linked in the description below. And additionally, Karen gave a shout out to our Practice Solutions Department ran by Juliana Stanley. You can find her contact information in the description below as well. Thank you again, and please be sure to tune into another ARMA webinar soon, and we hope to see you later. Thank you.